Hello, we are Group 32, composed of Krystal, Huey, Kyran Jones, Jamie Kwok, and Lauren Toscano, and today we will be going through a pharmacoeconomic study evaluation of an article entitled Screening for and Treating Postpartum Depression and Psychosis, a Cost-Effectiveness Analysis. This article was published in the April 2017 issue of the Maternal and Child Health Journal. To start off, we analyze the title of the article, which again was Screening for and Treating Postpartum Depression and Psychosis, a Cost-Effectiveness Analysis. Immediately, we can see that the authors did reveal the type of study which was being conducted here, which was a cost-effectiveness analysis. However, the authors did not reveal the perspective of the study, whether that will be coming from a societal viewpoint, a payer perspective, or the individual patient. Furthermore, the intervention of the study is not clearly defined here. All we know is that we will be looking at the screening and treating of postpartum depression, but not exactly in what aspects of those ideas we will be looking at. Also, it's not clear what the comparator will be. The setting of the study is also not indicated, as we don't know if we're going to be looking at this in a large teaching hospital, for example, or more on a small outpatient clinic basis. However, the bias of the study does appear to be at a low risk, given no results of the study are mentioned in the title, so it does not sway the reader one way or another as far as what to expect in reading the article. So next, we examine the objective of the article, which you can see here on your screen. So though this sentence was not expressly identified in the article as the objective of the study, we can see here that the objective is fairly clearly stated and straightforward. However, the authors could be a little clearer on the definition of postpartum depression and postpartum psychosis. It seems after reading the article that they classify postpartum psychosis as just a more severe form of postpartum depression. Therefore, they do not clearly explicitly state it here in the objective as a study as a separate outcome, even though the title does actually separate psychosis from postpartum depression. This could be a little confusing to a reader who wouldn't know to look out for the difference between the two. This sentence was located appropriately in the introduction of the article near the end, specifically after the authors explain the prevalence of the issue as well as the gap in the knowledge surrounding the treatment and screening of postpartum depression and psychosis. Next, we examine the appropriateness of the alternatives used in the study, which was the intervention of screening and treating postpartum depression compared to the usual standard of care. Despite the high prevalence and negative implications of postpartum depression, the standard of care in the U.S. is actually to not screen postpartum women for depression. Since the standard of care is not to screen for postpartum depression and psychosis, comparing this to our intervention of screening does appear to be an appropriate alternative to examine the outcomes that we are looking for. Further supporting the use of the intervention studied here in the trial, the Patient Protection and Affordable Care Act included postpartum depression screening in its definition of comprehensive women's preventative care. Also, the U.S. Prevention Services Task Force recently drafted a recommendation that all pregnant and postpartum women should be screened for postpartum depression. Therefore, our intervention does seem to be appropriate, as we'll be following the recommended guidelines by the U.S. government and also potentially replacing the standard of care, which is essentially to do nothing for these patients. As previously mentioned, the alternative of usual care in the U.S. is for women not to receive screening and treatment for postpartum depression. So here in our study, women must choose to seek care for their postpartum depression or postpartum psychosis in order to receive treatment. Once women make their choice to actually seek care, they have the exact same treatment course recommendations as patients being screened per our intervention here. Aside from the information already presented, the authors did not provide much detail or descriptions regarding the alternative of usual care, or information that may be a little bit more helpful in determining the appropriateness of this alternative, such as at what time point does the average woman seek care, if at all, and if they do decide to seek care, what screening method will be used on the average basis. These are all information that could potentially sway the results of the study, though they are not described here, so we can't fully say for sure if they will impact the results or not.
This study follows a hypothetical cohort of 1,000 pregnant women experiencing one live birth over a 2-year time period. Although the use of a hypothetical cohort was justified, the methods of determining that this was the type of cohort to be used for the study was not explicitly explained. This would be important for replication of the study. The time period for the intervention was justified as it was chosen to capture the majority of the impact of postpartum depression, or PPD, as studies have suggested that 95% of women with PPD will recover within 16 months of starting treatment. The authors also chose to use the validated Edinburgh Postnatal Depression Scale, or EPDS, a validated screening tool for PPD. Screening all women with the short form of the scale and then screening positive women for the long form has been endorsed by the Agency for Healthcare Research and Quality, and is the method that the researchers have used for screening for PPD. These screenings were assumed to take place during outpatient visits in the weeks and months following birth. The authors stated that a decision tree was used, rather than a Markov or microstimulation model, because decision trees are ideal for non-recurrent processes like PPD. The decision tree was developed by the authors and all calculations were programmed in Excel. Crystal Ball and Fusion Edition were used for the probabilistic sensitivity analysis. Overall, the authors sufficiently explained the methods used behind the intervention and justified most of their choices. The authors used a Medicaid payer perspective in the study because they cover approximately 50% of births in the U.S. They centered specifically in North Carolina in order to get the specific Medicaid fee schedules, all of which were obtained in 2014. The limitation behind their choice and perspective will be covered later on. As mentioned in the title, this study was correctly identified as a cost-effectiveness analysis. Outcomes were evaluated using total cost, incremental cost-effectiveness analysis, and quality-adjusted life years, the latter of which is used for cost-utility analysis. However, cost-utility analysis is a type of cost-effectiveness analysis. Therefore, the title stating that this was a cost-effectiveness analysis is appropriate. Costs included in the study for the Medicaid payer perspective were collected for an appropriate time period of 2 years postpartum, for those reasons previously stated. Costs, outlined in Table 2, include drug costs, personnel costs, namely that of the psychiatrists and doctors, treatment costs, and discontinuation of drug or treatment costs. Many assumptions were made about costs, which will be addressed later on. Some input estimates came from studies of European populations, as US-specific data are lacking, which could lead to inaccuracies in estimating costs for this population. Some additional costs that should have been evaluated include the costs of treating side effects from treatment, as this study did not evaluate these factors other than suicide and ideation, which could decrease the cost-effectiveness of the intervention. There were no costs associated with a woman delaying care in the usual care branch. This assumption is supported by the fact that spontaneous PPD remissions and relapses are rare. While the personnel costs were collected for weekly interpersonal therapy and psychiatrist visits, we are unsure if this is solely a protocol-related cost or attributed to the treatment. The authors did not explicitly state what the recommended frequency of visits with doctors and psychiatrists should be for treatment, and therefore the collected costs for the visits may or may not reflect real-life personnel costs.
The important outcomes were measured include total costs, number of remissions, no costs associated with a woman delaying care in the usual care branch. So this assumption is supported by the fact that PPD can spontaneously remit and relapse are rare. So women rarely experience relapses within the same postpartum period. Also, quality-adjusted life years, false positives, undiagnosed women, and suicide. Outcomes were collected for 2 years, which was determined to be appropriate in the previous slide. The study was conducted in 2016, so all costs were inflated to $2,014 using the medical care component of the Consumer Price Index. Both primary health outcomes, number of remissions achieved, and quality of life years gained were discounted by 3% in the second year for both screened and unscreened women. 3% is the commonly accepted rate of discount based on the Bureau of Labor Statistics in 2014. So it is important to keep in mind that this was a hypothetical cohort study, so many assumptions were made. It was assumed that 100% sensitivity and specificity for diagnosing PP with the EPDS. This is not an entirely unreasonable assumption because PP is a severe form of PPD. However, a sensitivity specificity of 100% will never be achieved, so this should be considered lower. It was also assumed that 100% of care-seeking women with PP would receive care. In the same vein as the above analysis, 100% of the patients may not get treatment, although it is a more severe form of PPD. It was assumed that the same proportion of women with PPD would discontinue treatment in the screening and usual care branches using data from a prospective cohort study. Attrition is random, so this is unlikely. However, it would be reasonable to consider attrition in both groups. It was assumed that women will receive interpersonal therapy if they were given a psychological treatment. Although this is considered first-line treatment, it is unreasonable to assume that all patients would want and completely adhere to this regimen. We found a study that showed that there is a difference between the care that women prefer and the care they receive. It was also assumed that all women in the cohort were covered by Medicaid until 2 years postpartum. This was addressed as a limitation in the study. They assumed that fluoxetine would be the prescription given for PPD as it is the cheapest per Medicaid fee schedules and is considered safe for breastfeeding. Fluoxetine may not be the best option for all patients considering patient-specific factors. Also, doctors may have different preferred agents. Also, women in the usual care branch who seek and accept treatment they assumed would receive 38 to 52 minutes of interpersonal therapy from a psychiatrist. So IPT is usually billed to Medicaid as 45-minute sessions, so this was acceptable. They also had assumptions regarding average duration of lag times in care episodes, and these were addressed in the references and appropriately assumed. The authors also assumed that bipolar treatment costs approximate the PP treatment cost, and that there are no costs associated with a woman delaying care in the usual care branch. This assumption is supported by the fact that PPD can spontaneously remit and relapse are rare. They also made the assumption that women with PP and PPD with suicidal ideation would have the same utility score as people with severe depression. This estimate was drawn from a comprehensive systematic review and economic evaluation of depression and anxiety treatments, so we assumed that the assumption was valid. The authors state that based on the ICER per quality of life years gained over a 2-year time horizon, routine screening and treatment of PPD is cost-effective under a wide range of willingness to pay thresholds, and this conclusion is robust to extensive sensitivity analysis. In addition to a one-way sensitivity analysis, the authors also performed a probabilistic sensitivity analysis, making distributional assumptions for each of the probability and utility input parameters. Authors did not include the cost parameters in either the one-way or probabilistic sensitivity analysis and worked under the assumption that costs to Medicaid are fixed by their fee schedules. Changing the underlying prevalence of PP resulted in the widest variety and variation in the ICER for the quality of life years. The ICER from the sensitivity analysis ranged from 11,281 per QALY gained to 24,117 per QALY gained. In all, 30 individual one-way deterministic analyses were performed. None of the test scenarios resulted in the intervention being dominated or dominating usual care using the 50,000 quality of life year threshold.
So in the top left of the screen, the commonly accepted $50,000 per quality adjusted life year gained willingness to pay threshold is graphed on the plane, and it shows that 93% of runs are cost effective using this threshold, which means that they fell below and to the right of the threshold. In the bottom right figure, you can see the cost effectiveness acceptability curve, which shows the probability that the intervention will be cost effective as compared to usual care for a range of willingness to pay thresholds. And this analysis finds that the intervention becomes more likely to be cost effective than usual care at a willingness to pay threshold of about $10,000 per quality adjusted life year gained, and it becomes cost effective in 95% of cases at a willingness to pay threshold value between $50,000 and $75,000 per quality adjusted life year gained. So this study had several limitations which were addressed by the authors. The first one was that the study only looked at the Medicaid payer perspective, and this could be a limitation because the cost estimations may not reflect the full costs absorbed by payers other than those with Medicaid, and also many women will most likely lose their Medicaid coverage before the end of the two-year time horizon that was used in this study, so it would not be as generalizable to them as well. Another limitation was that only suicide and ideation were considered as potential adverse events due to a lack of data. However, there are likely other adverse effects that might either decrease the cost effectiveness, such as treatment side effects, as well as those that may increase it, such as long-term effects of untreated postpartum depression. Another limitation is that some of the input estimates came from studies of European populations, and the authors stated that this was due to the fact that US data was lacking. And lastly, some physicians may feel proposed interventions are beyond their scope of practice. However, the authors state that this was responding to shortages in mental health providers overall, as well as following current guidelines from physician professional organizations on what to do in this situation. So overall, this study would be most generalizable to women of childbearing age in North Carolina who are currently enrolled in Medicare. Things that make this study not as generalizable to a larger population include the use of a hypothetical cohort that wasn't clearly defined, which makes it difficult to determine the generalizability in a general sense. As well, most of the information was taken from North Carolina Medicaid databases, so other states may have differences that were not considered in the study. Additionally, the authors received some of their inputs from European data, which takes away from the study's generalizability to the US overall. And lastly, since the authors only considered a Medicaid insurance, there's a large population that is covered with private insurance or other insurance types that this study may not be generalizable to. So though the study presents several limitations and assumptions that we addressed earlier, we can conclude that the conclusions of the studies that were reached are unbiased. Generally, the results of the study make sense. Increased screening and intensive treatment would be expected to cause an increase in both cost and effectiveness of an intervention. Also, compared to the usual care where screening is not done, more mothers with postpartum depression or postpartum psychosis would be detected, and therefore proper treatment would be provided to these patients. The authors also reference several other studies that support the conclusions of this study. Additionally, the authors don't overstate or overextrapolate the results of the study, which leads us to believe that the study is unbiased. Based on the perspective of the article, which was Medicaid, the total quality adjusted life years would be more appropriate to assess the cost effectiveness of the intervention, as Medicaid would be more concerned with overall increase in quality adjusted life years rather than individual incremental changes, which was only about 0.02 quality adjusted life years. We believe the results of the study because it seems to confirm the effectiveness of the intervention, which is already recommended by the U.S. Preventative Services Task Force. This study has also demonstrated the economical benefits of this intervention, which further supports its views. Additionally, the incremental cost effectiveness ratios of the intervention branch compared to usual care were $13,857 per quality adjusted life year gained, which is below the commonly accepted willingness to pay threshold of $50,000 per quality adjusted life year gain. Additionally, the cost per remission achieved was $10,182. So overall, although there were some limitations to the study, we can conclude that the conclusions drawn from the study are unbiased. And that concludes our presentation. Thank you for listening.